Next, let's talk about the diagnosis of pain and pain syndromes. Pain can be broadly classified into two different types, as we discussed previously. These are nociceptive pain and neuropathic pain. Nociceptive pain, also sometimes called physiologic, is almost always protective, and it serves as a mechanism to bring awareness to potentially harmful situations. It's usually acute, meaning it is of short duration. An example of that would be like a broken bone or a cut or an injury. However, nociceptive pain can sometimes be chronic, and the example that's usually thought of in the context of chronic nociceptive pain is low back pain. Nociceptive pain can be either somatic or visceral. Somatic pain arises from the skin, bones, joints, or muscles, and is typically throbbing type of pain and very well localized, meaning the source of pain or injury can be easily identified. Visceral pain is a kind of pain that arises from internal organs. Visceral pain can be either localized or referred. Localized visceral pain is easy to identify in terms of which organ is dysfunctional. In contrast, pain from an internal organ that is difficult to localize is termed referred pain, and I will explain further how that is identified on the next slide. The second broad type of pain is neuropathic pain. This is sometimes called pathophysiologic because this is the situation in which pain becomes harmful and is no longer protective. Neuropathic pain is often chronic in nature, meaning that its duration can be quite long. Because of this, treatment of neuropathic pain is often long-term. Neuropathic pain can be caused by damage to or abnormal function of central and peripheral nociceptors. Some examples of neuropathic pain conditions are diabetic neuropathy, postherpetic neuralgia, and fibromyalgia. Let me take a moment to explain how referred pain happens. The primary reason why pain from internal organs, also known as visceral pain, is oftentimes referred is because there are several afferent pain fibers, also called nociceptors, that synapse on the same spinothalamic neuron. As shown in this image, primary afferent nociceptors from visceral structures, such as the kidney, for example, converge on the same spinothalamic neuron as afferent nociceptors from somatic structures, such as the skin and bones. Because these primary nociceptors synapse on the same spinothalamic neuron, the body is not able to distinguish whether that pain is coming from an internal organ or from a somatic structure like the skin, bone, or joints. For that reason, pain in internal organs is sometimes called referred, meaning the area in which the pain is felt can sometimes be far away from the actual injured organ. A common example of referred pain is in the diaphragm. When there is damage or injury to the diaphragm, it is more commonly felt as shoulder pain rather than pain around the center of the trunk, where the diaphragm is actually located. The clinical presentation of pain depends on whether it can be broadly classified as nociceptive or acute pain or as neuropathic chronic pain. Nociceptive pain is usually well localized. There's obvious distress of the patient, and typically there is a very clear painful stimulus that is causing the pain, such as an injury or damage to an extremity. Nociceptive pain is commonly accompanied by autonomic symptoms like hypertension, tachycardia, sweating, mydriasis, and pallor. On the other hand, individuals experiencing neuropathic pain oftentimes do not have obvious suffering. The pain is usually poorly localized, and there is not always a clear stimulus that is causing the pain. Neuropathic pain is not associated with any autonomic symptoms, but it is associated with comorbid conditions such as insomnia, depression, and anxiety. As one example of a neuropathic pain condition, I will talk a little bit about fibromyalgia. Fibromyalgia is a condition involving chronic, widespread musculoskeletal pain throughout the body. As demonstrated in this image, the symptoms of fibromyalgia are widespread across the body and include central symptoms like headaches, sleep disorders, and dizziness, muscular pain, incontinence, vision problems, weight gain, cold symptoms, nausea, and morning stiffness. Fibromyalgia is approximately 9 times more common in women than in men. The pathophysiology of fibromyalgia is not well understood, but it is thought to be caused when a peripheral pain generator, such as a condition like arthritis, alters central pain processing, such that central nociceptors become damaged, and this increases pain sensitivity. Patients with fibromyalgia report hyperalgesia, which is an increase in the response to a painful stimulus, and allodynia, which is a response to something that is normally considered non-painful. Patients with fibromyalgia complain of severe, poorly localized pain all over. And because fibromyalgia is diagnosed exclusively on clinical symptoms, it is a diagnosis of exclusion. After everything else that has been ruled out that may be causing the patient's symptoms, fibromyalgia can be diagnosed. The assessment of pain in patients is oftentimes quite difficult. There is no specific laboratory test for pain, and the assessment scales that are utilized are subjective to the individual patient rather than objective. I will mention a couple of pain assessment scales on the next few slides. In addition, it's important to conduct a psychological evaluation for comorbid conditions such as insomnia, depression, and anxiety, because those conditions can alter pain processing, leading to a reduced pain threshold and higher reported pain. The primary pain assessment scale used in children is the Wong-Baker-Faces Pain Rating Scale. This uses a pictographic or an emoji type pain rating scale where a happy face represents no hurting or no pain, with faces going from maybe confused to indifferent to crying where it hurts the worst. Children are asked to choose a face that represents how they're feeling, and that is how pain is assessed. In adults, pain assessment scales may represent one of the options shown here. Visual analog scale, which is absent of any numbers or identifiers from no itch or no pain on the left all the way to the worst imaginable itch or pain on the right, and patients are asked to identify where on the continuum their pain falls. There might be a verbal rating scale, which is somewhat like a Likert scale with levels of pain binned into various areas from nothing to low to moderate to severe. Or finally, a numerical rating scale might be used where patients are asked to identify their level of pain on a scale from 0 to 10, with 0 being nothing and 10 being worst imaginable. For individuals with pain, their prognosis depends a lot on the type of pain that is identified. Patients with nociceptive pain typically have an easier time controlling their pain, especially when the underlying stimulus or injury is repaired or removed. Neuropathic pain, on the other hand, is oftentimes more complicated to treat and can require much longer-term therapy to manage. Now is a good time to pause and review diagnosis of pain and pain syndromes. Take a moment to think about the information that helps determine the type of pain a patient is experiencing and the severity of that pain. List the information that should be collected and assessed when developing a care plan for a pain patient. If you're feeling ambitious, You could even separate out this information by neuropathic or nociceptive pain type. Snap a pic of the QR code if you need some help answering this question.